These webinars are made possible thanks to generous donor support. If you'd like to contribute, visit our website at autism.org. Now, before we get started, I'll introduce our speaker. Dr. Jennifer Frankovich is a clinical professor in the Department of Pediatrics, Division of Allergy, Immunology, and Rheumatology at Stanford University. She directs the Stanford Immune Behavioral Health Program, where she and her collaborators have created a longitudinal clinical database and a large biorepository of patient and control biospecimens. She is collaborating with 10 basic science labs who aim to understand the immunological underpinnings of illness. And now I'll turn this over to Dr. Frankovich.
Great. Thank you, Denise. So as many of you've heard, probably me talking over the last decade, is that the last couple of decades, actually, there's more recognition of the overlap between inflammatory conditions and mental health. Many rheumatologic conditions have a high rate of psychiatric comorbidities, and we generally think of rheumatologic conditions as being triggered by infectious diseases. So these are my disclosures. So most of our funding comes from foundations and generous donors. So just a quick overview of all the inflammatory diseases, kind of in a broad scope, which are associated with psychiatric comorbidities. So we have the primary small vessel vasculitides of the brain, and then secondary vasculitides, including lupus, Behçet's, and other things. So when there's a systemic inflammatory disease that triggers inflammation in blood vessels in the brain. And then you have this big group of autoimmune and inflammatory conditions that directly affect the brain. So that would include things like lupus, limbic encephalitis, NMDA receptor encephalitis, Hashimoto's encephalitis. And then we have a group of conditions which the primary target area of the brain is the basal ganglia. And the basal ganglia is kind of like the central control system of the brain. Many of the tracts of the brain run through the basal ganglia, and it modulates signals. So Sydenhams Chorea is a classic example, which I'll go over today. Pandas and PANS, I can go over it today if you all have time, or we can save that for another time. Post-mycoplasma basal ganglia encephalitis, and then again, many of the systemic inflammatory diseases can also affect the basal ganglia. And then you have your white matter diseases, which usually you can see on imaging. So ADEM and multiple sclerosis, and sometimes these have comorbid psychiatric conditions. But most commonly, we see more systemic inflammatory conditions like psoriasis or psoriatic arthritis, spondyloarthritis, inflammatory bowel disease. These are the conditions where we see the highest rate of psychiatric comorbidities. So I wanted to start off with spondyloarthritis because this is extremely common in our population in general. So spondyloarthritis can give you inflammation in the spine, but the inflammation is microscopic and often does not show up on imaging until decades later, where you actually don't see inflammation on the imaging, but rather you see areas of fusion of the bone. So the symptoms of spondyloarthritis are pain and stiffness in the morning and with prolonged stationary positions. So long car rides, long plane rides, sitting still in a desk. A lot of people with spondyloarthritis have just learned to just move around a lot to keep active, and that helps actually, interestingly, control the inflammation. So patients with spondyloarthritis, 40% of those patients have depression and or anxiety, and fatigue and brain fog are very common among patients with spondyloarthritis. And again, you can have pain and stiffness in the morning with prolonged stationary positions. And the reason why I'm interested in this is because of the OCD that you can see So patients with spondyloarthritis have a higher rate of OCD and anger hostility. This has been shown among adults with spondyloarthritis compared to controls, and they're twice as likely to deliberately harm themselves. And interestingly, among patients with PANS, 30% of patients with PANS have arthritis, and of those patients, 50% will eventually develop spondyloarthritis. So we think spondyloarthritis is very has some type of connection to PANS, and I can go over that in a future talk. So patients with psychiatric disorders, so especially kids with autism, may not be able to articulate pain and stiffness. So this pain and stiffness is typically insidious. So when we've seen kids in our clinic with it, they don't tell us that their back hurts. They might be squirmy and they might get really upset with prolonged car rides or stationary positions, but they don't really know how to articulate the pain and stiffness because they have lived with it for so long. So you really have to look for clues in order to diagnose this. So oftentimes we're asking the parents about the morning gait. What do they look like when they crawl out of bed? Are they walking around like an old man or an old lady? And what do they look like when they get out of the car after a prolonged car ride? Do they look stiff? Is it hard for them to get out of the car? So some of those are the clues that we can use. And again, unfortunately, imaging is negative. But some of these patients have peripheral arthritis as well. So they can have arthritis in their knees or their ankles. And for that reason, we examine the other parts of their body and we'll get ultrasounds to see if we can diagnose it. So other clues for the diagnosis of spondyloarthritis, the biggest clue is that it's highly heritable. So if there's a mother or a father that has inflammatory back pain symptoms, so again, same things, pain or stiffness in the morning or with prolonged stationary positions, then we are very suspicious that it's occurring in the kid. You see this very commonly run in families. And as I mentioned, there's an axial and peripheral subtypes. So sometimes the back is not involved. Sometimes it's just the sacral iliac joints and the shoulders and the hips. So part of our exam is we look at hip mobility. Every kid should be able to do the duck walk, right? So squatting down and walking like a duck. Yeah. It's actually a screening test for the Army. Every person should be able to do the duck walk. And what we see is these kids have a really hard time because of limitation in their hip mobility. Enthesitis is very common in this type of arthritis. So this is where tendons and ligaments insert onto bone. So they will have maybe Achilles insertion tenderness or plantar fascia insertion tenderness. And the kids that I follow in our immune behavioral health clinic, many of them have tenderness along the spinous processes. So I don't know if you remember these little processes I showed you on the spine. Those can be very tender. So those bumps, if you have your kid kind of curl over the front and you press on those bones that stick out, if those are tender, that's a form of enthesitis. So, and again, these patients can have iliac pain, iliosacral pain and tenderness. You know, they may not complain of pain, but they may complain that their butt hurts, especially after prolonged sleeping or stationary positions. Also, they can have pain with tarsal squeeze. So the tarsal bones are the bones kind of just distal to the ankle. So not the forefoot, but kind of the mid part of the foot. That is very rare to have pain in that place, and it usually is always tied to spondyloarthritis. So when we're having a hard time examining the patients, oftentimes we'll examine the parents because it's so heritable. If we see this sign in the parents, then it can give us a clue that maybe the child has the sign, or at least the condition. We can also see comorbid psoriasis, and the combination of psoriasis and spondyloarthritis makes it sort of even more challenging from the inflammatory standpoint. And we actually see more psychiatric comorbidities in the patients with the overlap between spondyloarthritis and psoriasis. We often see bowel or signs of bowel inflammation. So maybe many of these kids have abdominal pain, constipation, alternating with diarrhea. In all of our patients where we're suspecting spondyloarthritis, we'll get a stool calprotectin. So looking at inflammation signs in the stool. And then again, just to emphasize, I mean, your kid or you as a parent may be in a lot of pain from inflammation, but that inflammation most likely won't show up on imaging unless the inflammation has been going on for decades. So the next condition I wanted to talk to you all about was psoriasis and psoriatic arthritis, because there is a very big overlap between psoriasis and psychiatric disorders, especially bipolar, depression, and anxiety, and fibromyalgia. And it's really tricky when patients with psoriasis have fibromyalgia, because part of their pain may actually be joint inflammation, and part of it is that their brain is amplifying the pain signals, and then it's not their fault. It's a pathway issue. And then the other tricky thing about psoriatic arthritis is the arthritis is dry, meaning you can't see swelling on exam. So oftentimes these patients are dismissed by rheumatologists because you don't really see anything. And that oftentimes the pain that the patient is reporting is out of proportion to the exam findings. And this is why we obtain ultrasounds, because the ultrasounds can pick up inflammation in the synovium, so the lining of the joints, and the outside capsule can be inflamed and painful. And you can see that on ultrasounds, but it has to be a particular type of ultrasound. And the radiologists have to have training in how to conduct and read ultrasound. So not just any ultrasound would do for this, unfortunately. And then the other challenge we see with psoriatic arthritis, because there's so much comorbidity with psychiatric problems, that the psychiatric symptoms either amplify the pain symptoms, and so the patient is then labeled as being a pain amplification patient, and they miss the underlying arthritis. But we've seen the opposite, especially in kids with autism, that their sort of OCD or other kind of neuropsychiatric challenges distract them, and they don't complain of pain at all. But they may still be suffering from the secondary effects of inflammation. And then again, the musculoskeletal ultrasound can be very helpful in making the diagnosis. And the other thing we see is that strep can trigger psoriasis, and we actually think it can also trigger flares in the arthritis and flares in the psychiatric symptoms. So if you have a kid with autism that suddenly deteriorates, look their skin over. Sometimes there's these really small plaques that have this silvery scale, and that might be a sign of a recent strep infection. So getting strep out of the household, out of the patient, giving the kid dilute bleach baths or magnesium salt baths, really to get rid of strep, can be part of the solution of recovering from this inflammatory situation. Common sites for psoriasis include behind the ear. Sometimes there's like a deep kind of crevice or line where the ear attaches to the scalp. You can also see plaques in the scalp, in the belly button area, the umbilicus, and the top of the gluteal fold. Those are places where psoriasis can hide. Oftentimes, these patients also have nail abnormalities. So it may look like their nail is disintegrating, called onycholysis, which can be misinterpreted as being a fungal infection of the nails. So if a patient does have nail findings and concerns of psoriasis, we often send them to a dermatologist with expertise in diagnosing nail abnormalities. Very commonly, we see nail pits, which are little like pinpoint dots in the nails. And this can also be a clue that there's arthritis in the DIP joint. And the DIP joint is that joint that's closest to the nail. And that is really pathognomonic for psoriatic arthritis. So if you see nail pits and there's some tenderness in that DIP joint, it's probably psoriasis and psoriatic arthritis. And then because psoriasis can run in families, not as strongly as in spondyloarthritis, but you can see it in family members. Typically, when we have a kid, with some type of neuropsychiatric deterioration, we're not only examining the kid for psoriasis, but we're also looking for it in first-degree family members. And then Behçet's syndrome is a multi-system inflammatory disease where 10% of the patients can have true neurologic disease, meaning something is seen on the MRI. But up to 40% of the patients have psychiatric disorders. In fact, bipolar is quite common among patients with Behçet's. Behçet's tends to affect people that come from civilizations that evolved from the areas along the old Silk Road. These patients often have recurrent oral ulcers, and they may or may not have scarring genital ulcers. They can have ocular inflammation, so meaning uveitis or inflammation in that anterior chamber of the eye. The arthritis these patients get is transient. So Behçet's is like multiple sclerosis or PANS, where it's relapsing and remitting. And the arthritis is very temporary. So maybe during a flare-up, they'll have arthritis for like 1 to 3 weeks and then it'll go away. We think Behçet's, these flare-ups that patients get with Behçet's, is triggered by infections. And it's not that the infection, that these patients have a hard time dealing with infections. They actually recover from infections very well. They have a very strong immune response to infections, but maybe the immune response is too strong and the body's not downregulating well enough. So we use medicines like colchicine to help prevent these flare-ups in these patients. So patients with Behçet's have many rashes. They can have acne-like rashes, pustular eruptions. Pseudofolliculitis is very common. So pseudofolliculitis, you probably all know what folliculitis is. So the follicles of the skin look inflamed, and it's not an infection. It's actually more to do with the hair folding over and irritating the skin. These patients can have nodules, inflammation of fat, so called paniculitis. They can have inflammation in blood vessels, all kinds of other things. And the other kind of common thing that these patients have is vascular inflammation. So Behçet's affects both arteries and veins. So if you ever see a patient that has inflammation in arteries and veins, that's almost always Behçet's, because you don't really see that anywhere else. And the other clue is pathergy. So a fairly large subset of these patients will get blisters at the site of blood draws. So what we ask the families to do is, after their routine blood work, to set an alarm so they can look at the blood draw site 24 hours later and again at 48 hours later. Sometimes that blister is delayed. And this condition is associated with HLA-B5. And oftentimes we see high von Willebrand's factor antigen or D dimers during the flare-ups. Okay, not consistently, but just during the flare-ups. So these patients can also have, multifocal deficits. But if you don't get the MRI at the time of the new deficit, then you may miss it. And the reason why is because the inflammatory lesions are temporary and they resolve, and you're just left with what we call a non-specific white matter change. So just because you're not seeing something on brain imaging doesn't mean that there wasn't a flare-up. You just might be missing it. So the area of inflammation becomes atrophied and it no longer has a signal. These patients can also have headaches, behavior changes, cognitive difficulties. They can also have brain fog, fibromyalgia. Some patients, will have a severe flare and they'll look encephalopathic temporarily, or they might have seizures temporarily, or temporarily they might have psychosis. You can see brain, if the lesion happens to appear in the brainstem or the midbrain or the basal ganglia, then you'll see associated symptoms. These patients are really hard to diagnose. The time to diagnosis is often very delayed, like 10 years. Even in areas where this is a common syndrome, and it's because the lesions can occur anywhere in the brain. And so it looks different with each flare. So it's hard to piece the picture together. And then after many sort of years of this, patients can develop progressive personality changes, psychiatric disorders, and dementia. So it's really key to diagnose this early and treat it aggressively early. And there's all kinds of non-parenchymal diseases. So again, inflammation of blood vessels can cause a thrombosis and give patients very severe headaches, which you're not going to see on standard imaging. You actually have to get imaging that brings out the venous system. So we call that instead of an MRI or an MRA, MR angiogram, we would get an MRV, so magnetic resonance of the veins. These patients can get pseudotumor cerebri, acute meningeal syndrome, strokes, and again, lots of comorbidity, fibromyalgia. For whatever reason, these patients can develop antibodies to the cell in the stomach where it's important for B12 function. So they can get a functional B12 deficiency and other vitamin deficiencies. They can also get ulcers in their bowel and get a condition that resembles inflammatory bowel disease. Okay, so that's Behçet's, and I'm going to go on to Sjogren's. So Sjogren's syndrome is another systemic rheumatologic condition where patients can get inflammation in their eyes and mouth. It affects their salivary glands, and so they get very dry eyes and dry mouth. They also have a lot of autonomic nervous system dysfunction, so they can have altered vascular tone and develop things like POTS. They can get esophageal contractility issues. They can get their food gets stuck. They have GI motility problems, cardiac rhythm abnormalities. They can have terrible neuropathic pain, which is burning and tingling and numbness. They can have proximal muscle weakness and sometimes elevated muscle enzymes. And this condition, you can also get personality changes and other psychiatric disorders, which makes it very hard for this patient population to advocate for themselves. The antibodies we see commonly with this patient population they're called SSA or anti-Ro antibodies or SSB, anti-La antibodies. But as we all know, antibodies can be falsely positive, so that's not the whole way you make the diagnosis, and they can be falsely negative. So if we really suspect this in a patient, we'll get a mucosal biopsy, a biopsy of their lip, and have a pathologist look under the microscope to see if they see inflammation in the salivary glands. So scleroderma is a very insidiously developing rheumatologic condition where over many years, even decades, slowly the skin hardens. And it can give, even before that, widespread vascular dysfunction. Early signs in children. So oftentimes we don't see the full-blown scleroderma until adulthood. But in kids, you can see Raynaud's, where the hands get very cold and they may turn white. You can see abnormal nail fold capillaroscopy. So this is we use these microscopes in clinic to amplify the blood vessels around the nail. So where the skin meets the nail, the skin is very thin. And if you put a little gel over the nail and you use a microscope, you can actually see right there in the clinic the blood vessels. And most blood vessels are, kind of thin and kind of the same caliber. But if they get really fat and dilated or tortuous, you can see some tortuous ones over here. That's abnormal, and that's a sign of inflammation in blood vessels. And this sign can precede scleroderma for many years. You can also see this sign in dermatomyositis. And we also see this, interestingly, in some of our PANS kids. So it's non-specific, inflammation of blood vessels, non-specific. You can see it with lots and lots of disorders. This just happens to be one of the many disorders you can see inflammation of blood, of very small capillaries. And imagine, it's not just happening in the nails, it's happening in the brain, it's happening in other parts of the body. So there's another entity, but this is very rare. It's called CNS, central nervous system vasculitis. So this is where you get inflammation that's focused in the brain. So, and you can actually see this inflammation on brain MRI. So in a kid with new onset headaches and a behavior change, this is on the differential. So any kid coming to our clinic who has a new onset headache and behavior changes, we're getting brain MRIs. And this is a very classic infection triggered, so group A strep triggered condition called Sydenhams Chorea. And it's a manifestation of acute rheumatic fever. So acute rheumatic fever can affect the heart, the skin, and I'll show you some pictures. Sydenhams Chorea has three components: emotional lability, plus or minus the psychiatric symptoms, hypotonia. So oftentimes these kids are kind of hunched over, and they kind of have a walk like they look like a drunken sailor, right? Their muscles aren't working well, and they're also weak. And then they also get chorea, which are involuntary, brief, random, and irregular movements. So these aren't tics, because tics are very regular, right? It's the same muscle group over and over. This is like, random muscle groups. So it can be of the face, meaning like maybe the cheek twitches and then the other cheek twitches and then the mouth twitches, and it just kind of twitching all over the face, but it's random and irregular. Or it can also affect the limbs. And in a kid, it can look like continuous restlessness. So sometimes the chorea is very severe and obvious, and sometimes it's subtle. And in clinic, what we do is we put a kid in a standing and sitting Rombert position where we're having them hold out their hands, and we're looking for these subtle movements. So the psychiatric symptoms that go along with Sydenhams chorea very much look like what you see in PANS. New onset OCD, irritability, emotional lability. So maybe the kids have easy crying or inappropriate crying or laughing. So they're laughing in a sad situation and they're crying in a happy situation. So their emotions may not be matching the situation. They can have outbursts of inappropriate behavior, irrational fears, which can lead to delusions. Distractibility, anxiety. Many of the families will say that their kid has suddenly become overly sensitive or mercurial and abusive. Many of these families will say their child went under a complete personality change, that the kid is not acting like that their true self. And oftentimes these patients have night terrors. And the OCD, you see in about 60% of patients presenting with Sydenhams chorea, and then 100% of patients at relapse. So this is what led Sue Sweeto at the National Institute of Health to think there may be some overlap between strep and OCD. And so she sort of aimed to look at a form of OCD that followed strep that wasn't clearly Sydenhams chorea. And what we've found is that this border between what is Sydenhams chorea and what isn't is very blurry. So it's often hard to say, like, yes, for sure that's chorea's, because sometimes it's just subtle and can be much more subtle than the psychiatric symptoms, which can be very severe. So here's a publication from, let's see, when was it? 1926. where Dr. Ebau, who was an expert in Denver, talked about the neuropsychiatric symptoms of chorea. So in general, I mean, there is some very rare genetic causes of chorea, but in children, new onset chorea out of the blue is always Sydenhams chorea. So even if you don't prove strep, and even if they don't have heart involvement and joint involvement, new onset chorea is always Sydenhams chorea, and you always treat the strep and you always clear strep from the house. So in this article, he talks about emotional lability as being the most constant observation in his study of these children. Children who previous to the onset of chorea were quiet and manageable suddenly become restless, irritable, extremely sensitive, and abusive. Some of these children became violent. For instance, patient 11 attempted to kill his younger sister or his younger brother. Another boy attempted to strike his brother over the head with a shovel. So this is very PANS-like, right? These kids were healthy, normal, going about their, normal lives, and suddenly they undergo this extreme personality change and become very aggressive and irritable. So it's the same thing has been described in Sydenham's chorea. So psychiatric symptoms, especially the OCD, can start even before chorea. So if you're a clinician and you see a kid with, new onset OCD, but you check them and they don't have any chorea, you should be bringing them back. So not only are you getting the labs to look for strep and swabbing and looking in the throat and looking in the perianal region and asking about impetigo and asking about all the other rashes that you can see with strep. But you have to reevaluate all of that. So 2 to 4 weeks later. So the chorea may be subtle or masked. Clinicians must actively look for chorea. So kids know when they make a movement and they didn't mean to, right? And so they'll cover it up. So a patient will, maybe sit on their hands to prevent their arms from moving around. Or if their arm does go up, they may just put it on the wall, right? So you really have to put them in a position like the Romberg position so that they can't mask these abnormal movements. You should also be looking for a milkmaid grip. So in Sydenham's chorea, because it affects the basal ganglia, these patients have failure to sustain tetany, meaning they can't keep the grip. So if they're carrying a gallon of milk across the kitchen, they can't hold that grip, so they might drop it. So a lot of times what we get is a history of the patient, dropping dishes or dropping the milk carton. And then because they can't sustain tetany of their tongue, they won't be able to keep their tongue out. So if you ask them to stick out their tongue, after, a few seconds, they'll pull it back in. And then, but they know they have to keep it out, so they'll put it back out. And it looks like a darting tongue. And it's really, they're trying to keep it out. They just can't. They have failure to sustain tetany. The other thing you might see is wormian tongue movement. So they might be able to keep it out, but it's really hard. So you'll see their little tongue muscle moving around. And again, it's not voluntary. They just can't do that. So other findings include truncal hypotonia. These kids oftentimes have a hard time keeping their arms up. So their arms may feel weak. And they can, it's rare, but they can have hyperactive reflexes or hung up reflexes. So their leg will kick up, but it'll suspend in the air before it falls down. You can also see that with really severe hypothyroidism, but most of the time when we've seen that, it's a reflection of basal ganglia injury. So the onset of chorea, so this is true with Sydenham's chorea and PANS pandas, can occur months after the strep infection. So the ASO and DNase B titers may be normal at presentation. You should still check them, 2 weeks later to see if you're seeing a rise or a fall. But, if you don't see that, it doesn't mean it wasn't strep. And we really have to fall back on the epidemiologic data that links strep to OCD. Other manifestations of acute rheumatic fever support the diagnosis, but are not necessary for the diagnosis. So the patient does not have to have carditis or valvulitis to prove Sydenhams chorea. Oftentimes we will have a history of migratory polyarthritis. So, what this means is maybe the knee would hurt one day, the next day the ankle would hurt, the next day the elbow would hurt. Oftentimes the family dismisses this. They're like, why my kid just, hurt their elbow on the playground and then they bumped their knee. Or the kid will make up a story on how they hurt each joint. But really it's a polyarthritis, and a single dose of Advil aborts the polyarthritis. So if you only hear them say their ankle hurt and then their mom gave them Advil, well, you're not going to have the evolution of the polyarthritis. After many episodes, patients can develop subcutaneous nodules. So these are kind of these thickened, nodules that are on the extensor surfaces of the limbs. It can even be on the bottom of the feet. And we've definitely seen this in our patients. And then erythema marginatum is a very classic rash, and I'll show you a picture of this. So mild cases of Sydenhams chorea without other manifestations of acute rheumatic fever may be mistakenly ascribed to behavior disorders, emotional disorders, restlessness. Remember, I was saying they can be in continuous movement, and clumsiness. So you really have to, carefully evaluate these kids to know whether they have acute rheumatic fever, and the treatment is very straightforward if you recognize it. So here's a kid who had a long history of having these kind of behavior deteriorations where he developed OCD and personality change and learning problems, but then he would recover and be fabulous. He was on this swim team. He was like class president one year, and then he would go into another deterioration, and he had many years of this. The first pediatrician he had, who had lived through the era of acute rheumatic fever, had diagnosed him with Sydenhams chorea, and based on a milkmaid grip and Wormian tongue movements. But he ultimately got an echo that showed that he didn't have any valve involvement. And so the diagnosis was removed. So he was not on penicillin prophylaxis and continued to have these periodic deteriorations. And then ultimately, he ended up with catatonia and showed up to our hospital in catatonia. And we'd gotten this history of these behavior deteriorations. So, Sydenhams chorea was on our differential. So we put warm blankets on him and left the room for like 20 minutes and came back. And sure enough, we saw this serpiginous rash. And the interesting thing about this erythema marginatum rash is that it moves around. So if you take a picture, you walk out of the room, come back 5 minutes later, the pattern is different. And there's no other condition in medicine that gives you this type of rash. So if you see this, the patient has Sydenhams chorea or acute rheumatic fever. This particular kid did not have any valve or heart involvement. Even though this rash you commonly see with the heart involvement, he only had the brain involvement. So the other way we look for this rash is patients that come to our clinic, if we're suspicious, we'll have the family put them in a hot bath and then take pictures of the trunk. So it's usually this rash is on the trunk. Take pictures of the trunk after the patient has been heated up for a while. You don't really see this rash unless you've brought it out with heat. So I mentioned before that you can miss strep, right? By the time the patient comes to you, the strep may no longer be in their throat, or they might not have elevated strep titers. And also a patient may come to you with a behavior deterioration, and it may have nothing to do with strep, even if they were diagnosed with it. So in each individual patient, you can't say for sure whether strep had anything to do with their deterioration. It is really epidemiologists that have taught us that there is a link between strep and mental disorders, most commonly OCD and tics. So strep throat infection increase the risks of things like OCD and tics. But in any individual case, you don't know, which makes it very hard as a parent and a clinician to commit to putting a kid on, 2 years of penicillin or lifelong penicillin to prevent further deteriorations, because you never know in that child was strep the trigger. But here's another epidemiologic study which points towards strep playing a role in at least some kids. So this amazing neuropsychiatrist, Tanya Murphy, did this study where she observed kids in line for a throat swab. So in the old days, every school had a nurse or a doctor that would screen all the kids for strep once a month and treat the ones that were positive. And that's how we were able to get the rates of strep throat very low, and that we saw acute rheumatic fever in Sydenhams Chorea go away, which is why we stopped screening for strep, even in clinics. But there are some counties in the United States, and for sure abroad, where acute rheumatic fever in Sydenhams Chorea is still very prevalent. And so the health department and schools still screen. So that's what Dr. Murphy did, was she watched kids in line for their routine throat swab. And her grad students rated all the movements of each kid in line and observed their behavior. And then ultimately, when they got the results, there was a high correlation between having a positive strep culture and the presence of tics, all these adventitious abnormal movements, and problem behavior observed in the line. And if it was a recurrence of strep, then that risk of having these abnormal movements of behavior was much higher. So again, another study that points towards this link between strep and behavior and movement disorders. And there's lots of animal models showing this link between strep and behavior changes. And there's a nice review article, but there's lots of animal models that show this link. And I only have 10 minutes left, but I will talk a little bit about lupus because, this is another, it's rare in kids, but among the more common systemic inflammatory diseases that we see as rheumatologists. But 25% of kids with lupus have neuropsychiatric symptoms, headaches, psychosis, cognitive dysfunction, and OCD is 10 to 15 times more common in patients with lupus. So in our immune behavioral health clinic, if someone comes in with terrible OCD, lupus is one of the things that we will work up. And then we see in lupus patients, they can have arthritis, inflammation in blood vessels, high immune complexes, activation of complement, and low C3 and low C4. So these findings are non-specific. In fact, we see a lot of these findings in PANS as well. But this is just signs of inflammation. And the MRI and the lumbar puncture or cerebral spinal fluid in patients with neuropsychiatric lupus, even though we know it's an inflammatory disease, you usually don't pick up on it in MRI and CSF. So that's it. That was the last condition I was going to talk about. So that leaves a little bit of time to answer questions. I did want to thank the clinical team that works with me in the Immune Behavioral Health Clinic, especially Margot Tienemann, who helped start the clinic with me, and Bahari, an amazing nurse practitioner that's been with me for a long time, and my other rheumatology colleague, May Ma, as well as our incredible psychiatrists, and the clinical research team, including Lori Colombo, Jackie, Cindy, who's been with me for a very long time, and others, and basic science team. Betsy Mellons, unfortunately, passed on this past March, but her two amazing postdocs are with me today, Nora and Ayan, and are carrying on the amazing work that she started in her lab. And we're hoping to hear from Nora and Ayan maybe next time. And then our imaging team, and then all of our amazing external collaborators, including Carlos Bustamante, who's trying to untangle the genetics of these neuropsych disorders, and Jill Hollenbach, who's also working with us on HLA, among many others. But thank you so much for your time. And if you're interested in any of the articles that we've written on PANS or some of these other overlap room psych conditions, feel free to go to our website. There's a publications tab where we list all of our publications, including our recent one depicting and characterizing the autoimmune diseases that you can see in PANS. Wonderful. Okay. So it looks like the first one is about is there any kind of blood test or labs to diagnose spondyloarthritis, which, is especially, hold on a sec, it's kind of loud in here. It's, it would be so nice if there was a lab test because the imaging is often negative in the early stages, but there is not. There is a genetic test called HLA-B27, and that's a predictor of ankylosing spondylitis, but it doesn't always clue you in if there's just kind of more routine inflammatory back pain. But this condition, this inflammatory back pain spectrum, is very sensitive to NSAIDs. So part of the diagnosis is based on, one, is there a response to NSAIDs? So like naproxen, too little naproxen in the morning, too little naproxen in the evening. Usually, after a few days of it or up to 6 weeks, patients will report a very significant improvement. Also, exercise helps with this condition. So if patients are reporting that they are much better when they're exercising regularly and much worse when they're sitting still regularly, that's another important clue. But there's unfortunately no lab tests. In fact, things like ESR and CRP can be negative, including for kids and sometimes adults. So the next one is for Behçet's. Is vascular inflammation visible, such as veins bulging? So it is not related to varicose veins. Varicose veins are very common. Those are the bulging veins. I don't know, maybe that there is a epidemiologic study linking it, but not that I'm aware of. These veins and arteries are usually deeper. And then the next question is, any body temperature, bilirubin, ferritin, carbon monoxide abnormal in any of these? So carbon monoxide I don't think it's ever normal. So if there's high levels of carbon monoxide, I think that's not normal. Bilirubin is non-specific. That usually means there's some liver involvement. So autoimmune hepatitis, you can have elevated bilirubin levels. Low ferritin, so that was an important question. So we can see low ferritin in Behçet's and PANS, and conditions like, restless leg or like lots of sleep disorders. And then those can be linked to psychiatric symptoms. So yes, low ferritin is something to pay attention to, but it's not a specific test for any of these. And then is Behçet's have the same signs as carbon monoxide poisoning? I mean, I think if you're seeing carbon monoxide poisoning, that's something different, but you can get basal ganglia lesions. And so if you got an imaging on someone and carbon monoxide poisoning was on the differential because there were basal ganglia lesions, then I would look into mitochondrial disorders. And I would say rarely Behçet's can affect the basal ganglia, but it can affect any part of the brain. So, okay, so another question, how do you diagnose basal ganglia issues? Good question. Maybe the next time I come and talk, I can show you the neurological exam that can give you a clue that the basal ganglia involved. So that would be like a positive glabellar tap. So if you're tapping between the eyebrows and the patient keeps blinking and it doesn't extinguish, that can be a sign. But there's also other signs. Milkmaid grip, I mentioned, creiform movements, overflow movements. Those can all be very subtle signs. Unfortunately, a lot of these basal ganglia inflammation disorders you don't see on imaging unless you look at a group of patients. So if you take a group of patients with Sydenhams Chorea or PANS or PANDAS and compare it to a group of healthy MRIs, you can see microstructural changes in the basal ganglia. But because everybody's basal ganglia is so different, like looking at it individually, you can't really pick up on the differences, unfortunately. Sometimes you can see inflammatory lesions in the basal ganglia, but I would be very strongly suspicious that there's an underlying mitochondrial disorder if you see that. So can you get Sydenhams Chorea, but not from strep, but another virus or bacteria? So it has been reported that patients with Sydenhams Chorea can have relapses with viruses. But I would say for the most part, if you see new onset chorea, but you didn't find strep, it's because you missed the strep. So Sydenhams Chorea is post-infectious, meaning the infection may have come and gone, and now you're left with the post-infectious inflammatory response. So it's not unusual to not see the strep infection at the time when the kid comes in to see you in clinic. And then the next question by Brooke, what do we know about the role of diet and gut health in inflammatory diseases? Great question. I mean, I think so many studies of rheumatologic conditions are showing differences in the microbiome. We're not quite at the stage where we're treating people with microbiome transplants or manipulations. But interestingly, some of these standard treatments of the rheumatologic conditions show these patients then develop an improved profile of their gut health. So in our clinic, we use a lot of sulfasalazine, and we do think that sulfasalazine helps the gut health because a lot of times the abdominal symptoms, the pain, the irregular bowel movements often gets better, the stool calprotectin gets better. And then the inflammatory consequences of the gut inflammation, so the back pain and the sacroiliac joint pain and the hip pain, oftentimes that gets better with sulfasalazine. And sulfasalazine has a sulfa moiety, and most of the action of the drug is actually inside the gut. Very little of it gets absorbed. So even though we don't know how to manipulate the microbiome, some of these medications that we've used for many, many decades, we think may be in part working because it's helping the microbiome in some way. Okay, so here's someone that said they saw me several years ago when he was a kid. He's now 25, has autism in PANS, has had 2 IVIGs, and that we weren't treating patients with both. Are you now? And do you treat adults? Okay, so IVIG has been a challenge because we definitely see, especially in new onset pandas, even Sydenhams Chorea, we see improvements. We don't always see improvements if it's been going on for a long time. And, every patient, just like any rheumatologic disease, sometimes IVIG works and sometimes it doesn't work. I think we hit a period of time where we were not having success with it. And then we learned something, and then we do have success. So one thing that we've learned is IVIG does not work if there's strep in the home. So if the patient still has strep in their sinuses or perianal strep, or there's a family member with strep, IVIG doesn't have much of an impact. So more recently, we've been using it more, but we work really hard to eradicate strep from the home. So we swab everyone in the house vigorously. We even have the family members do dilute bleach baths or clean with Hibiclens and really get strep out of the house. And once we've discovered that, we are having more success with IVIG. But if a patient is not on strep prophylaxis and they have this incredible response to IVIG, and then 2 weeks later, they suddenly deteriorate, it's oftentimes because of a new strep infection. So in our program, we try to keep kids on penicillin prophylaxis or some type of prophylaxis, maybe amoxicillin once a day or Keflex twice a day. But really, in these strep-triggered kids, we really try to prevent the strep. And yes, IVIG does seem to work better when we're doing that. And then the next one, is there any blood or other labs to diagnose spondyloarthritis? Oh, no, I already answered that one.
So
And then
can the kid have multiple conditions like the Chorea, Sydenham Chorea, and Bishop?
And Behçet's. Oh, we see
the
this
same
all the time. Yes. So in rheumatology, you can see overlapping conditions. And in our immune behavioral health clinic, we definitely see overlapping conditions. And interestingly, our old rheumatology textbooks suggests that there may be a link between strep and Behçet's disease. And we know Behçet's affects blood vessels, and we know that the basal ganglia can be hit. So yes, I think we do suspect that in some kids there is an overlap between Behçet's and Sydenhams Chorea. So then the question, does the clinic diagnose teen and adult patients? We do see teens, but not adults, unfortunately. But we're trying to get Stanford to let us start an adult clinic, but it's been challenging. And then a 31-year-old with ASD, PANDAS, catatonia. Oh, this poor child. CFD, seizures don't abate, and has the erythema rash. Who do we see? Well, if they have, I don't know if that's erythema marginatum or just an erythematous rash. I think you could try to see a rheumatologist to maybe look for arthritis, and carditis and other things. Maybe since there's seizures, maybe to work up lupus. But I know that there's a subtype of ASD where patients have seizures, and there's a lot of research pointing towards, ASD patients having some immunologic activation, inflammation, but I don't know the landscape of where you get care. Unfortunately, I think it's still in the research realm, which is so hard for these families because I think researchers have learned a lot, but it hasn't translated to clinical care yet, which is very hard. So then somebody is commenting on their son having EBV and Coxsackie. How do I help him? So I think that's a challenging situation because, a patient may deteriorate for lots of reasons and maybe even many inflammatory reasons, but we don't know how much EBV and Coxsackie are contributing, because all of us get EBV, and I think all children get Coxsackie. So I think that's a challenge to know whether EBV and Coxsackie are continuing to contribute to inflammation. There are some immunogenetic vulnerabilities to patients not being able to clear that subset of viruses, herpes viruses. So EBV is a herpes virus, and I think Coxsackie, although I can't remember, maybe you would know, Nor. But there are some immunogenetic tests that you can do to see if your child has a propensity. And though I don't know that treating those viruses will improve the situation. So is scoliosis or kidney involved in any neuropsych problems? So scoliosis, I don't know. I know a lot of patients with neurodevelopmental problems can have scoliosis, but I don't know that understand the link. Kidney, so if the kidney is leaking protein or blood or both, that might be glomerular nephritis, and that can be diagnosed on biopsy. And glomerular nephritis can be linked to lupus and other systemic autoimmune diseases, and can also be linked to post-streptococcal conditions. So I think a nephrologist, a kidney specialist, would be able to tell you why a kid is having leaking of the protein in blood based on the biopsy. So what age group do you encounter at our hospital? So we actually don't have a hospital-based service. We only have an outpatient clinic. So unfortunately, we only see patients outpatient. And, our clinic, unfortunately, is underwater. So we are only able to accept 1 in 10 applicants to our clinic at this time, which, and only our local kind of Bay Area population. That's our service area. We hope someday that every children's hospital will have an immune behavioral health clinic so that it can work up immunologic problems in these kids. But right now it's It's still considered controversial and maybe sort of on the edge of medicine. So I'm sorry if your local children's hospital doesn't have a clinic. That's terrible. And then what about spondylitis in older people? Is it the same thing? Yes. So it runs in families. So we often see, if we see it in a kid, we often see it in a parent, and oftentimes there's even a grandparent that has had long-standing back pain, maybe hip replacements. So it's or knee replacement. So it is strongly it runs in families, including the adults. And then the question about erythema marginatum rash, caused by heating and warming of blankets, shows a path of blood vessels. So it's not blood vessels per se. And then it's asking about heat shock protein and hemoxygenase. Oh, that's interesting. So there must be a scientist or a doctor here. So that's interesting. Hemoxygenase is something we're looking at in PANS, but we don't really see. So maybe we should look at it in Sydenhams Chorea. So thanks for that idea. And then autonomic signs. So we do see a lot of autonomic signs in our patient populations: lupus, Sjogren's, PANS, POTS. So all of these things that are mentioned. And then urinary incontinence is on the more rare side. We can see enuresis during PANS flares, and just kids that have had recent strep can have enuresis. But if the patient is always having incontinence, we would do an MRI of the spine. And then Neomar mentions many doctors around the world do not accept pandas. How can families connect with centers in the US, Italy, or UK for treatment? I think that's very challenging. I know the PANDAS network, the PANS physician network, and the Neuroimmune Foundation have all listed doctors on their websites that see PANS and PANDAS, but I think it's very hard because a lot of these doctors don't accept insurance. And so it's a tragic situation for families that can't get care. And I'm so sorry. Nora's trying to do the research, Ion's trying to do the research so that we can prove it's real and so that all the centers will treat. But right now it is very hard for families to get treatment. Let's see. Have you looked at overlap with Lyme disease and varicella? So Lyme disease, so our clinic focuses more on hyperacute onset, and so we haven't seen Lyme as causing a hyperacute onset. We think that's usually more with strep. We've even had some of our PANS-PANDAS kids get Lyme and not have a neuropsych deterioration. So I think what we're studying is mostly the post-strep, but for sure Lyme can cause neuropsychiatric deteriorations, and the way that's diagnosed is lumbar puncture and finding, sort of evidence of Lyme through that. And varicella, fortunately, since vaccines, we're not seeing the varicella associated encephalitis anymore. We have had some kids have very high titer varicella antibodies, but we don't think that that's necessarily the cause of the neuropsychiatric symptoms of these kids. Especially the strep-triggered kids can have a lot of nonspecific autoantibodies. So one of the toxins produced by strep nonspecifically activates B cells. And so you can just see a lot of positivity to many antibodies. But once you clear the strep and then you check all these antibodies like 3, 6, 9 months later, most of the time those titers do come down. So we think it was a nonspecific activation. And then the last question is about COVID and whether it has induced any of the conditions today. And that is, again, another great question. There's been some research in different labs, including PJ Utz, where he has shown that after COVID, patients can develop all kinds of autoantibodies, antibodies against cytokines, antibodies that you see in rheumatologic disease. Oftentimes those antibodies go away, but probably in people that were already predisposed, the infection does push them over. We have seen post-COVID arthritis and post-COVID, PANS. But what we think is that the patient was immunologically set up for those diseases, and then COVID pushed them over. So it's still important to treat those rheumatologic conditions with the standard of care. And typically we do see those kids get better. So Nora, I know that was probably hard to keep up with all
I
those
tried to,
questions.
I tried to type at the most relevant.
job.
Sure.
Thank you.
Yeah, so I think we covered all the questions except
Yeah.
in the chat. I don't see
I don't see any more questions either.
in the
So
chat.
yeah, sorry this went over, Denise, but
Oh, it's great. Thank you for
Yes.
sticking in there,
We covered
with
it all.
technical things. So we appreciate
Yeah.
it. And we would
Yeah.
love to have you both back next year and have Ian as well. So really
great.
appreciate your time today. And thanks to everybody who's here. We do have another webinar next week. We're featuring Dr. Lori Vismara. She'll be talking about early intervention that is conducted remotely. So talking about what they're finding about the impact of that, especially in the post-COVID world. So if you haven't signed up for that, the registration's online at autismwebinars.org. And we hope to see all of you back next time. So take care and we'll see you next year.
Thank you very much.
Great. Thanks, everyone. Thanks, Denise.